Dr. Ashish is a senior consultant at Ratna Jyoti Netra Kendra, Prayagraj, and he is going to be showing us a very interesting case and lot of controversial points to be picked up at that time. On to you, Dr. Yeah. So I would like to I've already introduced Dr. Ashish, and so we shall straight go on to your presentation, Doctor.
Thank you, Dr. Chitra
Hello
ma'am and
everyone, today I am
AIOS for
presenting a
giving me this
video
opportunity.
of zonular dialysis where you can see vitreous that was seen beautifully and where I went wrong. It is always very important to analyze your complications where you went wrong so that you can rectify that in your future cases. This was a hard cataract with that metallic sheen which I have discussed in my previous videos. Now see, I would be trying dry chop. The tip exposure is seen beautifully. I buried the whole of my tip into the nucleus, and when I tried to chop, there was the rotation of the nucleus with the bag itself. See again, this is a slow motion video. Again, when I tried to chop, there was the rotation of bag, and probably this was the moment where I had that zonular dialysis. Now after completing the emulsification of the nucleus, just see there is a blood clot at the side of a side port. I will be telling its significance later in the video.
At this point of time, I noticed that there is some laxity in the bag. There is zonular dialysis present. So after injecting Visco, I decided to put CTR.
So now after injecting Visco, the bag was inflated and I made another side port to help me insert CTR into the bag. And now you can see that leading heptic is being passed into the bag, and you have to be gentle. Your rexis should be intact for inserting CTR. Engaged it with one of the dialer, and the other dialer I'm using it to deposit in the bag, and CTR went nicely in the bag.
But after completing the case, when I placed intraocular lens, then what happened?
And then as I removed my cannula, you can see the IL started shifting to one side. Again I tried to close my wound as I thought that everything is fine, but then again when I went to this side port, I found this clot fishy again, and then I went with a butt swab, and now you can see that clot is engaged with a thread like fluid. See again, that clot is engaged with a thread like fluid, and that is the reason why my lens was shifting to one side, because the vitreous was coming from zonular dialysis side through this port outside. Now see how beautifully those vitreous stands are seen, and that clot is now inside the anterior chamber. Now again when I am sweeping, there is the fourth strand that is coming in. Now I will count these strands which are there in the anterior chamber. See how beautifully these vitreous strands are visible even without staining with triamcinolone. 1, 2, 3 and 4. I'll count again. 1, 2, 3 and 4, and this is the blood clot which was outside, engaged and mixed with the vitreous. Now it is in the anterior chamber. So now you can see, since I have brought that vitreous back into the anterior chamber, the IOL is not shifting to one side. Tear vitrectomy, this vitreous strands were removed, and see those vitreous strands are being removed with the help of cutter. The direction of my cutter is up, and I'm moving closer to the port so that if there is any vitreous strand which is passing from vitreous cavity outside through the port, that will be cut. And now the vitrectomy was almost completed. After removing Visco, I injected pilocarpine to check for any leftover vitreous. This is a double check mechanism just in case if there is any vitreous left, so it would give rise to peaking at that point. But you can see the pupil has constricted nicely, and now this intraocular lens was in bag with anterior vitrectomy done, and now the wounds were closed finally.
Thank you for watching this video.
Thanks a lot, Dr. Ashish. That was a
Thank you. Thank you, ma'am.
very nice video you showed, but I have questions which are going to be discussed with the expert panel first. The first thing is, I would question that first step where he tried to use a sponge or a spatula to sweep the vitreous, because this itself could cause an intra-traction and predispose to even a giant retinal tear. So using a triamcinolone acetonide to visualize the vitreous and then cutting it probably would still be the way to go. Thoughts on it from the expert panel?
Sweeping the vitreous absolutely is not the way to go. Chitra, I agree with you. Because every time you sweep, what happens is there is a traction on the vitreous base. And every time there is a traction on the vitreous base, there is a possibility of retinal breaks. So need to make sure. So once you see that the lens is going on one side, always use a preservative-free tricot there, diluted 1:3, I diluted, and then you know exactly how the vitreous stands, whether they're there in the AC or not. Another thing is, because he noticed intraoperatively, there is a zonal dialysis there, okay, the zonal weakness while you're stopping. So whenever you come out of the eye, always inject viscoelastic to expand the bag and come out of the eye, because he came out and then injected. So the very shallowing of the chamber itself can extend the zonal dialysis further.
Yes.
So you inject visco, preferably like sodium alernate or something like that, it will expand the bag.
The other question, Dr. Ramurthy or Dr. Arun could answer. Did you notice that there was a torque when he was doing a phaco chop? At that time, even that kind of a stress on the zonule where maybe a deeper purchase on the nuclear fragment and then just that burst of longitudinal phacopar could have impaled the nucleus better, and that torque would not have been there. Would you?
That usually happens once your hold is not very firm on the nucleus.
Yes.
So, and if you're not deep enough. So in hard nucleus, you bury your phaco tip, hold it firmly. The nucleus becomes an extension of your phaco tip, and then you go ahead with the chop.
Yeah.
So
Yes, Dr. Ramurthy.
No, Arul, have you finished? I mean,
yeah, I'm finished.
Okay. No, I think Arul made a very valid point. The only thing that could have been avoided, I thought the exposure of the tip was a little less. In the later step, it became a little longer, but initially when he buried the sleeve, the very little of the tip was exposed. That could have been one of the reasons that the hold on the nucleus that he got was less. So in hard cataracts, I always make it a point to make sure that at least a millimeter of the tip is buried. And before I chop, I ensure that the entire tip goes into the meat of the nucleus, which is done in a gutter. That gives you a fairly stable hold on the nucleus. And I think the most important point all of you have discussed is that, I mean, in today's world, we cannot manage a vitreous loss without using diluted triamcinolone acetate.
That was actually Dr. Ashish, it was a wonderful video which showed
Very nice
the
video.
way you displayed
Very nice
the three
video,
hands
Dr.
and all that. But then
No, I agree.
further question you, further put one question and then take all your answers. Would any of you all think at that point of time, doing a pars plana vitrectomy be a better option than doing an anterior vitrectomy? Yes, Dr. Ashish, you want to answer that?
Ma'am, I'm a retina surgeon as well. I've been practicing retina from Chitrakoot, and I do cataract and retina both.
Yes,
so in most of my detachment cases also, I have stopped using triamcinolone, because what I feel, I agree, for most of the anterior segment surgeons, triamcinolone is a must, because you need to visualize vitreous that gives a very good visualization of vitreous. But trust me, even without that, you can actually visualize vitreous strands very beautifully in the anterior chamber. And I agree with the expert that sweeping with an iris, this iris depositor, it might cause a bit of traction on the retinal break and cause a tear. But then you have to be very gentle, and very valid points were taken, like a use of iris depositor should be careful, use of triamcinolone is actually advisable. But even in my detachment cases, I have stopped using triamcinolone to stain while doing PVD also. And I've been, except for pediatric cases and except for coloboma RD, where there isn't a PVD initially. But in most of the detachment cases also, there is a posterior vitreous detachment All you need is to look for that V's ring, and you just have to hold it and pull it to the anterior base. So agree with the experts. Their all comments were valid, and I totally agree with them.
So what about the other thought? Would you, in this kind of thing, even I would have done an anterior vitrectomy only, but do we going forward, would it make sense to do a pars plana vitrectomy?
It depends. It depends whether you are just an anterior segment surgeon or if you do practice posterior segment also. For us, doing a posterior segment, like I am a posterior segment surgeon as well. For me, doing a pars plana vitrectomy is not a big hassle. I can make one port or maybe an anterior chamber or another port for the fusion, and I can do a pars plana vitrectomy also. And that some people have advocated that they do go ahead with a pars plana vitrectomy because that gives a better cut of the vitreous from behind, from posterior, behind the capsule. But for an anterior segment surgeon, I think cataract, as we are discussing, it is this talk is more for an anterior segment surgeon.
Yes.
So for them, doing the pars plana vitrectomy is definitely not a viable option because you can cause more damage than better for the patient.
Yes, I think unless a person is really an expert in pars plana vitrectomy, trained in that, it makes sense to do an anterior vitrectomy. But by doing a pars plana vitrectomy, theoretically, you are actually losing out less of vitreous, and you can contain that area of dialysis. It will not increase more. So that could have been an advantage. Although, of course, the CTR was placed. That was a
Dr.
very
Chitra, may I ask her?
Yes,
Dr. Chitra, can I ask a quick question? Dr. Ashish, what is against using triamcinolone? Because for a beginner, I think who may not have a brilliant microscope.
Sir, I agree. All points were valid. For a beginner, triamcinolone is a must because they do not know how a vitreous appears. Because I've been doing vitrectomy a lot because I do retinal detachments, I do diabetic vitrectomy, and detachments also I've seen is in kids, in children, and in patients who have pulmonary RD. PVD is not there. It is a must because you need to peel the cortical vitreous as well. Because if you leave behind cortical vitreous in the retina, that will definitely give rise to PVR and a redetachment later on. So most of us, probably I was from SNC Chitrapur, and I know many of my fellows, many of our colleagues also, they are of a habit. It's a matter of thing that what are the telltale signs that tells that vitreous is still in the vitreous cavity. Because if you inject pilocarpine, if there is no peaking, if your pupil is moving freely, if it is getting dilated on doing hydro or something, that shows there are telltale signs that tell that vitreous is not there in the anterior cavity. And you have to check certain points like whether your vitreous is in the ports or not. Because if you are living in vitreous in the ports, definitely there will be some peaking at one point for sure. And after injecting pilocarpine, there won't be circular dilatation as I shown. So there are certain telltale signs which tell you that whether vitreous is there or not. And trust me, as I've shown, if you go and see these videos on YouTube also, if you go and see, those 4 strands are seen beautifully. I've counted them. 1, 2, 3, 4. And while I was doing this surgery, I had this in mind that I had to show this to the students. I had to show this on YouTube. The see, without staring, even that vitreous strand can be seen beautifully.
Agree. 100%.
No, Dr. Ashish. I think, these webinars are meant for sending home a message. And your video was excellent. You are a great surgeon, but whether experienced or a novice surgeon, I think in today's world, using triamcinolone acetate, yes, I also used to, as an inexperienced surgeon, I used to believe that if you have a round rexis, if you have a round pupil and there's no peaking, there's no vitreous in AC. I used to get away with it. Today, even if just I had a PC rent with no vitreous in AC, after the entire surgery is over, after the intraocular lens in place, I have a round pupil, I inject a little bit of diluted triamcinolone acetate. And there have been instances when, to my surprise, I find there is a stand of vitreous that is peeping out. So, yes, you can get away with it, but if you want to leave behind a message, then I think that it costs us nothing. It takes a minute or so, and using a diluted triamcinolone would be the way to go. Of course, you can get away without it.
I just add one point, Ram.
Yes.
Chitra.
Yes.
No, Ashish, in today's world, I think triamcinolone is a must, especially for anterior segment surgeons, because we have different types of microscope. Number one, okay, we have high quality microscope, low quality microscope. We may not be able to differentiate. And vitreous is a colorless substance. Number one. Number two is, I have seen in my experience, Ramurthy has also mentioned just now, we got a round, nice pupil. But if there is no there is a vitreous strand which is coming there, which is not getting attached to any of the wounds or anything like that, then there will not be. It's just lying freely in the anterior chamber. Okay, the pupil will still be around, but post-operatively, by surprise and shock, you'll see a vitreous moving like that in front of your eyes. Okay, that is because there's no attachment of this vitreous. So unless you put tricot, you'll not be able to remove this vitreous. So that is why in glued IOL surgery, all the secondary implant, always the end of surgery, I put tricot to make sure there's no vitreous there in the anterior chamber, even if the pupil is round.
Not only that, it decreases the chances of post-op inflammation.
Yes, Dr. Ashish, it was good you showed that video because there was a myriad of thoughts which we came forward and all of us kept learning along the way.